Good. Everybody hear me okay?
Loud and clear.
All right. We'll talk a little bit about brain injury today. Thank you for joining me. I do have some disclosures before we start, and that's that I am a speaker and a consultant for Exobionics and on the Speakers Bureau for Kindred Rehab. A little bit about my background. I went to medical school at Tulane University in New Orleans, Louisiana. Did my residency at Baylor College of Medicine here in Houston, Texas. I went to Seattle for a fellowship at University of Washington in brain injury medicine and stayed there as an attending for a very short period of time before returning to Houston. Currently, I am the medical director of Post-Acute Medical Rehabilitation Hospital in Humble, Texas. I'm also consulting physician at the Emerging Consciousness Program at Nexus Specialty Hospital, and as Rosalie mentioned, the director of Early Career Physician Development. All right, so kind of three objectives and categories tonight. We're going to talk about the epidemiology of traumatic brain injury, a little bit about the pathophysiology, the subsequent classifications, and the prognostication. So I typically start with the CDC definition. A traumatic brain injury is an injury to the head with accompanying factors, typically changes in consciousness or cognition that bespokes to a traumatic brain injury. For those of you interested in billing and coding, these are some of the ICD-10s that typically accompany traumatic brain injury. And on that note, without belaboring it, we'll jump into the epidemiology. I happen to think that the best epidemiological numbers come from the fall study. Of note, it was published in 2010, so the data is getting a little bit old, but I just don't think that anyone else has published it or looked at it the way they have. That estimation was that 1.7 million traumatic brain injuries occur each year, where that works out to about 200 out of every 100,000 people and result in 52,000 deaths. There's lots of other diseases that get a lot more press and media, but traumatic brain injury is extremely common, as you can see from this graphic. That works out to about 4.5 million Americans with TBI-related disabilities, and a lot of those are younger than 45. So they're going to live with that disability for the rest of their life. So I think minimizing that disability and rehabilitation is extremely important. There are kind of three groups when I'm talking about traumatic brain injury: the first group, the middle group, and the last group. First group being those younger than 5 years old, the middle group, kind of that 15 to 24-year-old adolescent to young adult group, and then the geriatric population. And I think this graph really does it justice. So you can see the solid blue line are the emergency department visits. And there's lots of young kids who come in for the falls and hits to the head that occur when your balance and your coordination isn't good, and your head is the largest part of your body, of course, at that point. But as you can see, there are few hospitalizations and almost no deaths related to it, thank goodness. If you go to the middle group there, you can see that the emergency visits are high, not as high as they are for the young children, but fairly high. But also the hospitalizations are much higher. And that's because a lot of these injuries are occurring from those high velocity or high trauma incidents, mostly young adults doing things they shouldn't do, drinking and driving, racing their cars, jumping off of bridges, things like that. And then finally, you see the last group, the geriatric population, those over 65. Emergency visits are much elevated again, but so are the hospitalizations and unfortunately the deaths, because these tend to be very fragile people who don't survive as well. If you look at this, the gender breakdown, much more men than women, almost a 3-to-1 ratio, but almost all of that occurs in that middle group, because it's primarily young men, typically as testosterone is peaking, that really do risky behavior. And so the pediatric and the geriatric population really don't account for this 3-to-1 ratio. It's almost all that middle group. Being of low socioeconomic status, of course, is a risk factor, unfortunately, and so is alcohol, which is almost ubiquitous in that middle group again. Thank goodness most of these injuries are mild or concussional type injuries oftentimes. But that 20% moderate to severe is where I do most of my work. You can classify a brain injury based upon different factors, and I've given you the chart from the Department of Veterans Affairs and Departments of Defense that kind of outlines what you can use. In particular, I think looking at the loss of consciousness and the post-traumatic amnesia are extremely important, and we're going to come back to those ideas as the talk progresses. If you look down at where they come, falls is the #1 at the time of this study, and actually it may or may not surprise you to know that it has actually increased, and it's now typically more than 40% when you look at the epidemiology. Does anybody have a guess why? Well, it's because of the baby boomers. If you think of that last group, the geriatric population, most of those individuals are experiencing traumatic brain injury because they're falling, they're getting older. And as that segment of the population increases, we're getting more and more falls in that elderly population. Here it is broke down numerically. If you're more of a numbers person, you can see how the ER visits, the hospitalizations, and the deaths are all quite different. And again, my area of expertise is typically that middle at one, the motor vehicle traffic injuries. And you can see that there are a relatively high number of hospitalizations and deaths for a lower number of ER visits compared to some of the other diagnoses because of the high velocity. We're going to get into that. All right. So now the point where I get really excited and all of you fall asleep, the neuropathology underlying this. So if you think about it, your brain is this big squishy organ, right, inside of a very hard skull. And so when it gets injured, there's kind of two injuries, the immediate injury and the secondary injury. Let's spend a few minutes kind of, what? So the kind of the primary injury and the secondary injury. And let's jump in and kind of dissect that primary injury rather quickly, if you don't mind. And slides are stuck. So just to foreshadow, my computer crashed when I was playing with the videos and the slides earlier. So I tried to minimize the videos. Hopefully we're good, but if it crashes, that was me trying to be too cute with the videos. Apologize. So the primary pathology injury that we're going to talk about first is the contusional injury. Again, you've got the soft, squishy skull kind of rattling around inside this hard, soft, squishy brain rattling around inside this hard skull. And so you can get contusional injuries or kind of bruises on the brain as it travels around inside of that skull. The areas that are most at risk are the frontal lobe and the temporal lobes because they're in the front of the brain and they have an easy time contacting the skull right there. You can also get what you may have learned in medical school as a contra coup injury, which is a fancy French word, which just means the brain kind of bounces off the front of the skull typically and then rebounds on the back of the skull. It's a diametrically opposed injury because, again, it has to bounce off one side to hit the other. We'll have a graphic if I've lost you on this one. So here it is, kind of a graphic, if you will. The baseball bat is hitting this unfortunate person in the front of the head and moving the skull back with such force that it impacts or causes a bruise on the front of the brain. The brain then, because of its elasticity and its kind of squishy nature, will bounce off of that skull and go back and hit the back of the skull, causing a second bruise to the back of the brain. So you end up with a bruise both in the front and the back, as indicated here and again here. And of course, this one doesn't just magically go away and a little purple arrows show up. It maintains its bruised state. Cool. And this is what it looks like on a CT. You can see a little bit of blood in the front, a large area of edema secondary to bruising. And if you squint really hard and kind of, look at it through a hourglass, you can almost kind of see the little bit of contra coup back here. There's a little bit of edema. All right. So that's one primary injury. The second primary injury is the one that we get really excited about in brain injury, and that's what a lot of people refer to as diffuse axonal injury or centripetal injury. This is caused by rotational forces. So again, if you can imagine that squishy brain, and I assume most people on this Zoom have had neuroanatomy, that brain's kind of squishy, right? When you got your fingers in it, it was kind of gooey. So it's not an inert substance. It has different densities at different layers, and different tissues are connected together. As that brain starts to twist and move in the skull, as it's rotating or moving, you have tearing apart of those different tissues, both based on their different densities, as well as their locations and how squishy or stretchy they are. Now, it's most often affects the axon, so that's why we typically call it diffuse axonal injury. But really, the entire neuron or cellular structure is injured by these types of injuries. And this is not a hard concept. In fact, you're actually really used to this. If you think about spinning plasma in a test tube, you know that you're going to pull apart those red blood cells because they're the heaviest as they spin around, and the proteins and the other factors are going to come to the top because they're the lightest. That hopefully is a pretty straightforward idea. And just think about the brain doing the same thing. Now, the tracks that are most at risk are those long tracks because they have to stretch the farthest, so they're often broken. The severe breaking of those long tracks through DAI is where we get our vegetative state and our severe disability after traumatic brain injury. And you most commonly see that in the great wide junction, the corpus callosum, and the interventricular septum. You want to know why? because again, you have different densities that are right next to each other right there. So as the heavier things are being pulled harder apart, the lighter, less dense substances are not being pulled apart. At the same time, the brain is kind of twisting or shearing, if you will, and those squishy ones, of course, they can twist and bend pretty easy. The harder substances have a harder time accompanying those forces. So for a bunch of different reasons, that's where the brain kind of breaks apart or has the most damage. If this is putting you to sleep, I'm going to move on in just a second. But if it's not, at the bottom, I have the citation. It is really a phenomenal article to read about how the biomechanics cause this diffuse axonal injury. It's really a phenomenal read if you're into this. All right, so I didn't draw this, although I think I could have, because it looks like a third grader did. But the idea here is that the reticular activating system, that kind of, remember the 4F part of your neuroanatomy, it kind of lives in the bottom of the brain, that almost like lizard part of the brain that's been there for eons. But for us, for humans, we're not lizards. If you believe in evolution, and I'm in Texas, so I do have to say that, the thinking part of your brain, the human part, is that cortex. And we need those two to connect and talk if we're going to be conscious. Those tracks, though, are very, very sensitive. They're not durable. And so losing connection between the cortex and that lower ascending reticular activating system is how we lose consciousness. And so it doesn't matter if we're talking about a sports concussion like boxing or football, or the most severe traumatic brain injury due to multi-car, rollover motor vehicle accident. It's all that same pathology. You're breaking the connection between the cortex and the reticular activating system here. So even though this drawing is ridiculously silly, and I agree it is, it's to me the best example, a demonstration of what it is that you're losing with those injuries. All right, so the reason that brain injury guys like myself get excited about diffuse axonal injury is because it only really happens in severe traumatic brain injury. It's what causes that loss of consciousness, and the reason that these individuals have such profound deficits, but I think are also so rehabitable, have the rehab potential. All right, and this is a CT of diffuse axonal injury. Now, if you're looking at it and thinking, boy, that doesn't look so bad, you're absolutely right. Because remember, diffuse axonal injury is not a big honking injury somewhere that you can just scoop out a chunk of brain like a contusion or a stroke. You've got little small injuries to the entire brain. And so if you can see there's little white dots kind of all over the brain here and there, that's actually blood vessels in areas where the structures have torn apart from each other, and a little bit of blood and substance and edema has occurred there. So that's what these are. But that's it, right? That's what we're talking about. The whole brain kind of being shook up, not one focal area. So again, if we talk about the injuries, we have our primary injuries, which we've covered with the contusion and the diffuse axonal injury. Now let's really nerd out for those of you who are into it and talk about secondary injury. When you have a traumatic brain injury, the first thing the brain does, like any part of the body, is start to have edema or swelling, right? So if you stub your finger, if you sprain your ankle, think about any injury you will, the first thing that happens is that edema occurs. The difference is, of course, the brain is inside this hard skull, so there's no room for it to expand. So the second thing that happens is you start to increase the intracranial pressure because all of that edema has nowhere to go. Well, it forces down pressure on the arteries and the veins, so you end up decreasing the perfusion that gets to the brain. Well, as the brain gets less perfusion than it needs, it gets further unhappy and you have worsening edema, and very quickly you result, it has a mind of itself. And pretty soon you end up in this feed-forward cycle, which keeps getting worse and worse. As the trauma itself injures the cell membranes, you lose that cell integrity. So you have a shift of your anions and cations, which cause a whole bunch of downstream activity, none of which are good. And again, I'm an editor for the PM&R journal, so I will definitely support the Cigna-Reddy article as what I think is the best explanation of how that works if you want to read it further. But for those of you who may have tried to forget this part of biology class, remember the sodium, chloride, and calcium are outside of the cell just floating there. And on the inside, you have your healthy negative 70 millivolt resting membrane, negative action potential. So as that cell membrane breaks, you end up with the sodium, chloride, and calcium coming into the cell, depolarizing it and causing all kind of havoc downstream. Other things that happen, you create free radicals, you undergo the whole inflammation and acuronic acid cascade, and you lose the blood-brain barrier, so more badness flows into the brain, right? Because it's not able to filter it out. So all of that results in cellular membrane depolarization, changes in the blood-brain barrier, yada, yada, yada. And so the metabolic demands continue to increase because the brain's got to try and hold this all together. And it needs, obviously, oxygen and glucose to do that. But it's not getting it because if you remember our secondary injury, we're getting less perfusion because of the edema. So the badness just continues to feed forward until the initial injury is compounded by what we call the secondary injury. So not uncommon for the patient to have the injury, not look good necessarily, but not be doing that bad, and then to deteriorate over the next few hours or even sometimes up to 2 days. All right, so I'll try and wake everybody up now. Let's talk about something a little more physiatry focused, and that's the TBI assessment. There's a bunch of different scales out there, and I've tried to highlight the ones that I think are best, and we'll go through each one of them, talk about the pros and cons very briefly. So the Glasgow-Coma scale is probably what you first learned in medical school. It's here. I'm sure you've already memorized it. If you haven't, you need to for the board exams. And there's some genius here, but it is relatively a straightforward and easy scale, basic scale, if you will. So the kind of limits what you can do with it. One thing you can do with it is assess whether it's a mild, moderate, or severe injury. And that's broken down for you here. Just based on the initial GCS, you can make that determination. There are some caveats that you have to keep in mind. Number one, after traumatic brain injury, people are typically not happy. They just had a traumatic event and their brain's not working 100%. So that ends up being often labeled agitated, which I think is a horrible word, but it's what we're stuck with. And the GCS is not very accurate in those individuals. Secondly, as we mentioned, intoxication, especially in that kind of 14 to 22-year-old range, is almost ubiquitous. And obviously alcohol is a depressant, it decreases the accuracy of the score again. Third, as everyone on this call knows, the brain has two major halves, the right and the left. And if there's a lot more injury to one half than the other, which is usually the case, the GCS can't pick up on that and account for why one side's so bad, one side's so good. So it could be overestimating or underestimating the injury. Next, as these injuries are traumatic spinal cord injury can coexist, and that doesn't happen infrequently. And obviously the GCS is not going to work if you can't move your arms and legs. And then finally, and oftentimes, unfortunately, most importantly, it's not accurate after intubation. And if the EMS in your city or state are anything like in Houston, Texas, they're taught to almost intubate right away, regardless, sometimes even regardless of whether or not the patient needs it. So once they're intubated, it's really difficult to get an accurate assessment. But the Glasgow-Coma scale does have its redeeming qualities, and that's that although Dr. Jeanette, when he put it together, probably didn't understand this in the 1960s, what he's essentially measuring is the function of the different levels of the brain. So that to get a perfect score, you need to be able to engage your cortex. To get the middle scores, you really only need the middle parts of your brain. And then to do poorly, of course, you just need to activate the lower parts in the reticular activating system. So way back before they understood this concept fully, he was able to put together a scale that kind of adequately assessed how much destruction had occurred to the reticular activating system. So it really is a genius scale from that perspective. The Ranchos Los Amigos scale is used a lot. It was created by neurologists, so naturally I don't like it, but it's out there, so you have to know it. Unfortunately, it really isn't helpful for prognostication or anything else, but it gives you a rough idea of where the patient is. I suppose it has some utility. Post-traumatic amnesia for me is where the real money's at. And this seems like a hard concept, but just bear with me. I think you'll find it pretty easy once I explain it. All we're really looking at is the time from when the injury happened to when that individual can make new memories. And this is actually really well correlated with the severity of the brain injury. We typically measure this with the Galveston Orientation Amnesia Scale, or test, but there are a couple other scales. It's certainly not the only one, but it was the first. We'll absolutely rep it because it's from Galveston, Texas, just down the road from me in Houston. And it's a scale that assesses both the remote memories, the time of injury memories, and the post-injury memories. So it really covers it all. What you're looking for here is an individual to have greater than 75% on 2 consecutive trials, at least one day apart, of course, to say that they're out of post-traumatic amnesia. And this is a picture of Galveston. It doesn't look like this. For those of you who are unaware, we got hit with Hurricane Nicholas 2 days ago. Everybody's still recovering a little bit, but it is a very nice place to vacation if you are interested. All right, so 16 items, max score of 100. And again, you're trying to get better than 75. Here's the scale in case you want to look at it. It may have some copyrights, I don't know, so careful where you use it. There is something that you can take away from this, however, and that's that the length of the time in post-traumatic amnesia, or more simply stated, the time from the injury to the time the patient makes new memories, is a really good prognosis of how they're going to do at 1 year. So if that person can demonstrate that they're making new memories by scoring greater than 75 twice on the GOAT in less than 2 months, then they're probably going to be pretty independent at 1 year. If on the reverse side, if they can't make new memories by 3 months, then the chance of them being very independent is very unlikely, with 90% confidence. And I think that's a powerful tool to have when you're discussing severe traumatic brain injury. The disability rating scale is also out there. It is not very good at prognostication, unlike PDA. But however, unlike post-traumatic amnesia, you can actually see day-to-day changes, which is exciting for the patient and the family. So it also has its pros. And then everybody uses the Glasgow outcome scale. That's how we define how well someone's doing. Dead, hopefully, is self-explanatory. Vegetative is not the term we prefer anymore. We like unresponsive wakefulness syndrome now. But essentially, the patient kind of has an on-off switch, and that's it. Severe disability means they're, dependent for almost everything. Moderate disability means there's some things they can do independent, but they still definitely need help every day. And good recovery means that they're doing most things on their own, but they don't have to be back at work or driving. Those really high-level tasks sometimes are just not reasonable. All right, so the takeaways, hopefully, is that the Glasgow Coma scale is grossly associated with outcome, but doesn't give you any finite detail. The Ranchos Los Amigos scale is not related to outcome, but a good descriptor. Post-traumatic amnesia duration is really good at predicting what's going to happen. It doesn't show you day-to-day changes. And that hopefully we're continuing to study this and improving our ability to assess the outcomes in the prognosis. So let's talk about prognosis, right? Because that's kind of exciting. So you have this severe traumatic brain injury patient in front of you. The neurosurgeons and neurologists typically are not very good at this. So they ask you what to do. So this is a real life story. This guy's name is Danny Fernandez. And don't worry, he signed all the papers. There's no HIPAA violations. I'm very close with him and his family. He had about as severe a traumatic brain injury as you can. He was unconscious for a long period of time, struggling with the disorder of consciousness, and came to my rehab really not able to walk or talk or do anything. Minimally conscious was probably the correct diagnosis for those of you who are familiar with this term. He did very well, and you can see him there in the wheelchair, kind of up and looking around. And here he is, not long after he got here. We threw him in our exobionic exoskeleton, and I admit I'm a show for the company, but that's what we had. And he did phenomenally well. He woke up, he was able to take steps, he engaged the therapist. It was like he was a whole nother person. And his recovery just really took off from there. He did phenomenally well. And he came back a year later to win the Patient of the Year award and pick it up. And he was walking independent, talking independent, doing all of his own ADLs, hadn't gotten back to work, but had really done phenomenally well. So this is why I think people love traumatic brain injury. It's such a great field because you can really, really help people with tremendous recovery. But was he a one-off? Am I cherry picking this one just to impress you and to gain a few more Twitter followers? Of course. The first look at this happened by the Multi-Society Task Force in 1994. And they just looked at all of these patients who were unconscious because they didn't really have all the sophisticated terms that we have now and what happened. And they found for these traumatic injuries, surprisingly, either they got better or they died, but they didn't really stay unconscious. And that's consistent with what we see in real life and what further research has validated. Of those who get conscious, a lot of them actually have pretty good recovery. You can see 17% of them, even before we had, rehabilitation guidelines in place, had moderate disability, and 7 of them had a good recovery. We're really independent for everything. So this kind of got everybody's gears turning and people thinking about how we can better address this. And again, I think just another graph saying what I've hopefully already described. The consciousness really improved. Nobody at time 0 obviously was conscious. They wouldn't have been in the study. But by 3 months, 6 months, and a year, there'd have been a tremendous improvement in consciousness. So we looked at people who had severe traumatic brain injuries and had been in really good rehab centers. For those of you already in the field, model systems are places, rehab centers designated by the government as having really good rehab and given extra money to study what they do well and patient outcomes and those kinds of things. So of about 400 patients who had come into rehab centers unconscious within what we now call the disorder of consciousness, almost 70% regained consciousness during rehab. 23% of them emerged and were able to make new memories on the PTA, as we talked about, And again, 70 of them, about 70% went home. So that was, really good news. It seemed like rehab was a good investment in these individuals. They followed those same individuals at 5 years. And when they looked at them at 5 years, they split them into two groups. One was the group of patients who had recovered during rehab, who were following some commands and able to do things. Of those patients at 5 years, more than half were doing really high-level independent things like problem solving, and 85%, almost 90%, were either able to ambulate or use a wheelchair for mobility at an independent level. So really had done really, really well, right? What about those patients who didn't wake up and didn't make conscious progress on their consciousness during rehab? Well, despite that, 5 years later, between 20 and 40% of those individuals could do something independent. So maybe it was brushing their teeth, maybe it was washing their face, but something, right? So that was really encouraging, that even if we didn't make the progress during rehab, were we kind of setting these individuals up for success? You guessed it. We then reevaluated these patients at 10 years. And what we found was, regardless of whether they had woken up during rehab or not, in fact, most of them at this point were the individuals who had not, 80% of them were able to walk to some degree, 72% were able to bathe independently, 80% again could manage their bowels, and 57% of them were even independent for high-level cognitive tasks like memory. So I think there are a couple of take-home points before we open the floor up to questions that I want you to think about. Number one, what does a really good rehab candidate look like, right? So many times I think as physiatrists, we get hung up on these things about, can they tolerate 3 hours? Do they have the support? What's the progress going to look like? I've just shown you individuals who were unconscious when they started rehab, who did 3 hours a day and made good progress. So hopefully it challenges a little bit of what you think of as your criteria for inpatient rehab. Secondly, what are the benefits of rehab? If you're in the field already, you're probably racking yourself with what we used to call FIM scores. Now we call them GG. It's how we measure progress during rehab, and it's really important to the bean counters who are involved. But look at these individuals who had great progress 5 and 10 years later. Maybe the real benefit is that we're teaching the patients and families how to work with these individuals, how to build towards success, and we don't have to see success from day 1 to day 5 within the rehab center. But I think most importantly, I hope it causes you for a second to think about, how do we evolve our care for all individuals so that everybody has a chance to recover and gain their maximal independence? Because as physiatrists, I think that's really our calling and what we hope to do. So here's some random references if you want to read more. But let's open the floor up for discussion now. Rosalie, I'll turn it back over to you. And
great, thank you. That was a fantastic presentation. I liked it. So yes, everyone can type their comments into the chat box, and I'm going to get started with some of the comments from the questionnaire and also some of my own. So Dr. DiTommaso, you mentioned how alcohol is related in about half of TBIs. What effect does that have on brain healing afterwards?
That's a great question, and nobody's really kind of put their thumb on that. Certainly there's nothing good that happens because of alcohol. Some of the studies have shown that when someone was intoxicated, they actually outperformed the prognostic data. And so there was a group of researchers who were postulating that alcohol at the time of injury was in some way neuroprotective, but reanalysis has really shown that probably what it's doing more than anything is suppressing the GCS score, which is really important in prognosis, as we mentioned, and making them look as if they were more injured than they really were. So I think that that's the only thing I can say on an evidence basis. And then I can just say, obviously, alcohol has neurotoxic effects. It can potentiate seizures. So there's really no positive to alcohol for the brain or brain injury.
Okay, thank you. And on the subject of seizures, do you have any post-TBI seizure medications that you like to use?
Sure. So we have level 1 class A evidence that a seizure that occurs at the time of injury doesn't need treated. A seizure that happens after 7 days needs treated. But those ones within 7 days, we're not sure. However, they are amenable to empiric treatment. The best tested medicine for that is phenytoin, but there have been non-inferiority studies with Keppra or levetiracetam. I don't know if I'm allowed to use brand names in this forum. Levetiracetam is a mouthful, but that's what most trauma hospitals use now for days 1 to 7. And then you typically stop and see if they have late or post-traumatic epilepsy after.
Okay, so we have one question in the chat. How do you manage patient and family expectations with recovery? Managing the patient's self-efficacy, willpower, mental state seems incredibly difficult, especially when the family gets involved. So how do you manage that, and how do you give them hope?
Yeah, I mean, that's a great question, and it certainly is not something I could answer in even the whatever remaining time we have left. We could talk for hours, if not days, about all of the nuances of engaging families, individuals in their recovery. One, I think you always have to remain optimistic. Hopefully, from the data I just showed you, there's almost always hope if the patient isn't brain dead. Brain dead is different, right? That's not what we're talking about. But even if they're vegetative or unresponsive wakefulness, as we're supposed to call it now, we still see recovery later on, as that data showed. So I think educating them that there is possible hope at the end of the road, but being realistic about where the patient is now and the course to get there is the best place to start. And just trying to be as open and honest with the patient and the family as possible is always the place. And then you have to just kind of read the cards as they come out. As setbacks occur, as the family reacts, you've got to deal with those emotions and help channel them in a positive direction. You certainly can't do it all by yourself. You need a team, and that's why I think it's so important to partner with the neurologists and neurosurgeons as much as possible, but also your rehab allies, your physical therapy, your occupational therapy, your speech therapy, and neuropsychology if you have access to those, because all of those individuals can help to show the patient and the family what it's going to take to get where they want to go, and make them a little more both realistic, but also hopefully hopeful about getting there.
Mm-hmm. And so when it comes to PT/OT, speech therapy, what are the standard treatments, or what are the most successful treatments for post-traumatic brain injury patients?
Sure. So, I mean, I had a medical student ask me this recently, and the way I phrased it is, what's the most efficacious treatment for diabetes? Well, it depends on the patient factors, what they're eating, how they're responding. So I would never say that there's one specific thing you have to do. You've really got to kind of read the patient and their deficits and tailor it appropriately. And that's the beauty of being a physiatrist, right? Mm-hmm. Certainly in the more severe injuries, one thing I'm a big fan of is getting them up and moving as soon as possible. Newton's law that an object in motion stays in motion and an object at rest stays at rest. If you can get some of that momentum going, oftentimes you'll uncover a lot more that the patient can do than you think when they're lying in bed. Yeah, and that reminds me of the video of Daniel in the exo that you showed earlier. So what was Daniel like before he went into the exo? Could he move his legs at all? Yeah, so he was clearly minimally conscious. You know, at times he would interact with the external environment, but for the most part, he would either have his eyes open or closed and very little interaction. Some people were even calling him unresponsive wakefulness at that point. I did not feel that was the accurate diagnosis once I saw him, but other people were saying that that was the correct. Clearly, as you can see in that video, once he got up and moving, he was conscious and interacting. So he just really needed that push to get going. I wish so much I had that video of what he looked like laying in bed, but he was pretty non-interactive. Yeah, I'm sure it was a night and day difference. And so Juliet has a good question as well from the chat. Is there a way to determine the type of primary injury clinically through symptoms or a neuroexam? And I'll add on also through imaging. And is the typical recovery path different from the types of primary and secondary injury? Yeah, so the contusional injury will present a lot more like a stroke, and kind of there's a focal deficit depending on the part of the brain that's injured. So if your exam is sensitive, sometimes you can pick up on that. The diffuse axonal injury, of course, by definition affects everything to some degree. And really, you're worried about the unconsciousness there and how long that lasts. So from an exam, that's probably the things you're looking to pick up on. Now, assessment of disorder of consciousness is a whole nother topic, and we could go down that rabbit hole if you want, but I don't think that's where the question is going. And the second part was imaging. Of course, I tried to show you two images. MRI is, of course, more sensitive than CT, but to differentiate diffuse axonal injury from basic contusion, you can typically do that just with CT. Is there a way to compare counter-coup versus the centrifugal? Centripetal force? Right, resulting in diffuse axonal injury. So that's going to be all centered around kind of that loss of consciousness. So the only thing that you're physically examining for that is really the length of time that they were out to gauge how severe that is. And the GCS to some degree, as we talked about. Okay. And so if it's more of a contusion type injury, is that more like following stroke care treatment? Right, so you may see an aphasia with that. You may see a hemi-neglect. You can see focal motor deficits like a hemiplegia or a monoplegia. Those kind of focal deficits will show up after a contusional injury because it is more similar to a stroke where you've got a more focal area of the brain that's impaired. Typically, because the frontal lobes are so involved, what you start to see is changes in personality. And that's a very common finding after traumatic brain injury, of course. If so much of that comes from our frontal lobe and the executive function is housed there.
Mm-hmm. And is the rehab process itself, like the work with physical therapy, is that all the same as with stroke patients then?
Very similar, yes. I think stroke patients, because the ACA tends to do a lot of the frontal lobe, it's a little less common that you have so much emotional and behavioral type deficits in stroke. You get a lot more of that typically with TBI. So the PT and OT have to be able, and speech therapy, of course, have to be able to account for that in their interventions. When the patient gets frustrated, when they get sad, when they're having a bad day, they're going to lash out. They're going to not handle it well. Whereas maybe the stroke patient's more able to think about it and work through it. So you've got to kind of factor those things in.
That's a very good point. And so when it came to centripetal forces, I was imagining, well, first I imagined that carnival ride that just spins you, but I don't think we're talking about those. That's probably from a car accident where they roll over a few times or spin. What other history questions should you ask, or what should you look for?
Yeah, so the thing you've got to look for is always the loss of consciousness. Loss of consciousness implies injury from a centripetal type injury. And that's why even if you think about boxing or football, when someone has a concussion, it's usually not a head-on collision that causes that. There's some twisting, right? It's always the uppercut or the hook in boxing, very rarely the jab that knocks somebody out, unless there's a tremendous amount of head movement with the jab, because you've got to spin the head in some way to cause loss of consciousness. The same is true for motor vehicle accidents or anything else.
That's really interesting. I never knew that about boxing. That's good to know.
Sure.
Let's see. And somebody else asked, what medications are you using to help TBI patients?
Yeah, so we really only have one evidence that has a large randomized controlled trial, and that's amantadine. If you get a chance, Giacino and White, they're both rehab guys, had a large randomized controlled trial with the most severely brain injured patients. And they showed that with amantadine, you can actually potentiate recovery. And so it's a really good study. So not to say that I use it on every patient or in every scenario, but that's a really good place to start and a good read if you're interested in the field.
Also regarding medication, we had a question in the survey earlier that, pardon my French, what medication do you use for agitation in TBI? So if you could just talk about, the word agitation and what you'd rather call it, and kind of just talk a little bit about that.
Sure. So, again, you've got to realize that these are people who are not dealing with their complete frontal lobe. So if they're lashing out at something, it sometimes comes from them, but a lot of times they don't have the ability to think of that on their own. Something has set them off. So the first exercise you've got to do, and I know that the person who wrote this question alluded to that a little bit, is that you've got to see if there's something in the environment that's making them angry. Were they not able to sleep at night? Do they have a headache? Is the room too hot or cold? All of those things are really important in a first step to getting it under control. If you don't remove that irritating stimulus, you're never really going to get it there. Once that happens, I think that agitation comes in lots of flavors, right? There's a brain injury patient who's sad because they're in the hospital. They're angry because the nurse gave them a shot. And so if you're going to pick a medication, you should do one that addresses the symptoms, right? So something to kind of treat anxiety, if it's highly anxiety driven, maybe a light benzo, although I know that is controversial. If the issue is that they're overwhelmed, maybe something to help them focus or block out the periphery, like a methylphenidate or amantadine might work. So unfortunately, there's not a silver bullet. Agitation is a syndrome, not a single diagnosis. And the more that you can delineate the underlying characteristics, the better you're going to be able to help that patient.
Okay. Yeah. Okay. And so what about the future of TBI medicine? Where do you see it going and what excites you the most?
Yeah, that's a great question. I think so much research has been poured into finding something to minimize the primary injury or prevent the secondary injury from progressing. And as far as I'm aware, none of those studies have ever shown any benefit. So I'm sure they're going to continue to pour money and resources into that. But I think the recovery and the rehabilitation hopefully will continue to evolve just as quickly. And I think we are making a lot of progress there. We have both guidelines from the American Academy of Neurology and American College of Rehab Medicine about how to address these patients and how to think about prognosis. And the American College of Rehab Medicine has also published guidelines on what's appropriate for the rehabilitation, the minimal competency in order to do disorder of consciousness rehab. So I hope that the field continues to evolve in perfecting what we do to help these individuals, to push them along their path to recover better, quicker, more appropriately.
Mm-hmm. And I mean, just thinking about that exoskeleton video, that was super incredible, especially hearing how he was before. Is there any other brain-computer technology that you think might be coming up soon, or developments with exoskeletons?
Yeah, I mean, I think exoskeletons will continue to evolve. I think that there are lots of different people getting into robotics, even brain robotic interfaces. So I think all of that's really exciting. Also, there's been a lot of research done on using magnets and electrical stimulation to try and modulate the brain after an injury to perhaps improve recovery or to turn back on, so to speak, areas that are not functioning well. So I think, all of that would be very exciting to see, and hopefully the field continues to progress in that way.
Mm-hmm. Coming back to our osteopathic roots here, we are the AOC PM&R. Do you know of people using OMT for traumatic brain injury and specific craniosacral therapy? Have you heard anything about that?
Yeah, I know that there are people who do that in practice, and a lot of the patients really love that. Being an MD, I have to admit I'm not as familiar or comfortable with it, but I know that it's out there, and I know that some people really, really take pride in it. I don't know of any recent research, but that doesn't mean it doesn't exist, and I'm just unaware.
Mm-hmm. And so for our medical students, how would you recommend that they build their application, build their hands-on skills, and get ready for clinical rotations and residency?
Yeah, I don't know that spending a ton of rehab is always my recommendation for medical students who are interested. You have to do enough, obviously, to understand the field. But if you're in rehab, you'll see once you're there, there's going to be elements of everything that are going to touch your rehab patients in some ways. Elements of neurology, nephrology, cardiology, pulmonary. The more that you can keep yourself well-rounded and knowledgeable about medicine as a whole, the more powerful you're going to be for your patients. So I think certainly expose yourself to rehab, make sure you have a gross idea of what it is. But if you're really kind of set on rehab already, if you feel like you've had that exposure, then sample a little bit of everything else and make sure that you're well-rounded, because that's going to pay off for you tremendously.
Mm-hmm. And if you had to choose the top three, electives for someone to do, what fields would you recommend them spending time in?
I mean, I think neurosurgery is great. I think neurology is great. And then I think something like pediatric behavioral or developmental peds is really helpful. Working with babies, children, and young adults who are struggling with neurological disabilities really teaches you a lot about the fighting spirit and overcoming obstacles, and I think gives you a good mindset once you get into physiatry. So I think if you can find pediatric PM&R, but maybe a related field will give you a different perspective, because you're going to get pediatric PM&R in your residency. So something along those lines, though, where they're dealing with young adults, young individuals with neurological deficits and disabilities, that I think really does a great job of setting the field for you.
Mm-hmm. That kind of reminds me, earlier in the presentation, you showed how most traumatic brain injuries happen under 5 years old. So how does pediatric care differ?
Pediatric care is an awful lot different. In fact, there's entirely separate guidelines for the management and rehabilitation of that. Honestly, I've never done pediatric TBI, so I am not an expert on that. But I think that the core idea is that, they have so much development to go. You've got to make sure that you're continuing to expose and challenge those children to a whole lot of different things, because they're going to need that stimulus to really grow and to become the people they need to be. So it's an important part, I know.
Mm-hmm. And then I had a kind of pathophysiology question from earlier. So because geriatric populations, they typically have more brain atrophy, I would imagine they'd be more prone to traumatic brain injury after a trauma. but less prone to edema because there's more space to swell. Would you agree with that?
So definitely they benefit from having a little bit of space to swell. I couldn't argue with that. They're also at very high risk of having subdural hemorrhage. And while I think a lot of, especially neurosurgeons, don't get excited about subdural hemorrhage because there isn't typically a high morbidity associated with it, the blood itself and then the breakdown products of that blood as it's reabsorbed do irritate the brain and the neurons and slow recovery. So from a rehab perspective, that's something very important to note and to prepare for when those patients are matriculating to your rehab center.
And is there any way to clean out those blood products, or do you just have to symptom management at that point?
So if they're severe, certainly there are criteria for which they can be, the neurosurgeons will go in and kind of clean them out, so to speak. But oftentimes the thought process is that the risk of infection and further bleeding is high, that they'll just watch them. And it's true, the mortality related to subdural hemorrhages is typically not incredibly high, from the hemorrhage itself at least. But it definitely, I feel, does slow the recovery, and there's research to back that up.
Okay. So Max has another question. It's a 3-part question, so let's just start with the first part. So you mentioned that you don't work with milder TBIs because they generally resolve on their own. Do we understand that correctly?
So I would say that the loss of consciousness usually resolves on its own. Certainly postconcussive symptoms, as we're understanding more and more, can drag out and impair patients for long periods of time. I used to work with a lot of mild traumatic brain injuries, but just the way my practice has evolved, I don't do that anymore. So I think that if the question is, does postconcussive syndrome exist? I'd say absolutely. I think some of these people are incredibly bothered by the symptoms for a long period of time, but should not have a prolonged loss of consciousness or disorder of consciousness related solely to a mild traumatic.
Mm-hmm. And so what is the treatment for postconcussive symptoms? I mean, I'm sure it's symptom dependent, but overall.
Right. I mean, I've seen almost every postconcussive syndrome symptom you can imagine. I mean, problems with sleep, problems with breathing, problems with blood pressure, problems with concentration, you name it. And so you've got to really kind of hone in on what's going on, and treating it symptomatically is almost always the best way to go. There's definitely not a golden bullet, a silver bullet. And when you think of it, I mean, the brain controls who we are, right? So much of it is our personality and our preferences, and all that comes from the brain. So when you have a brain injury, almost anything can be affected, and people really do struggle with that. It's a tough go for, a lot of people.
Mm-hmm. Oh, I had a question I wanted to ask on that topic, and I completely forgot. Oh, I remember. So would you say treating post-concussive symptoms and maybe concussions and things of that nature, is that more neurology? Is that more physiatry? Is that more family med, sports med? Who's kind of taken hold of that field?
Yeah, I think it's still very well split. I think all of those people you've mentioned, along with psychiatry, and orthopedics, have gotten themselves involved in post-concussion management. And there really isn't a right or wrong. Everybody has their own particular style and perspective. Obviously, I'm a physiatrist. I think most physiatrists do it best, but I'm, of course, very, very biased on that. So I'm sure if you ask your average family med, they'll say they do it.
Yeah, I'm sure. Okay, so the last question that I have from the survey questions earlier is that what should emergency medicine interested people take away from this lecture? What can you do in the acute phase?
I think the number one thing, hopefully, that everyone takes away is that even in the most severe injuries, there's always hope, right? I hopefully showed you very strong data from very stringent research that shows even 10 years, people are still recovering and improving their independence. So just because somebody presents to you in the ER, in the operating theater, on the wards of your neurology rotation, and they're not doing much, they haven't recovered very much, that in no way means that they don't have the potential to recover. And as the PTA prognostication information indicates, you've got to wait 2 months before you could even begin to make any kind of determination on what the 1 year recovery is going to be. So 2 months is a long time to wait, I understand, but that seems to be the nature of the brain. Again, we're still seeing improvements 10 years later, and the brain is going to recover on its time, not ours. So you've got to just be patient not say, oh, well, too bad, not waking up, and pack in the camp.
And is that 2-month period, is that extended for geriatric populations and shortened for pediatric?
So those kind of guidelines aren't out there. We definitely know that once you're over 65, your chances of having a good recovery are much, much lower. But the PTA, all you're really doing there is assessing the slope of the curve, right? We know that brain injury almost always improves. So the question is, how fast is it occurring? So the measurement, the outcome all depend on the time you measure it and then what your goalpost is. For that study, we looked at 1 year. So we're really interested in, if you use the PTA with any confidence to predict what the person will do at 1 year. If we had predicted 5 years or 10 years, it would make the research more difficult, but we would probably have a different outcome. So it really just depends on how you're trying to assess the slope of that curve.
Oh, thank you for explaining that again.
Sure, of course.
There are all of questions. Unless anyone has any last minute questions, you can turn on your microphone or post it in the chat, whatever you feel comfortable at this point. Dr. DiTommaso, do you have anything else that you'd like to add?
No, thank you all for showing up. I'm really honored that so many people would come out on a Wednesday night at 8 o'clock and listen to me babble on about brain injury. So very humbling, and thank you all very much.
Well, thank you so much. It was a great presentation. I really appreciated the pathophysiology. That was my favorite part. Oh, we have, what's this? Oh, a clap. We have a clap. All right. Well, thank you so much and have a good night.
Everybody too. Be safe.